You may recall I'm Angeline True here from Prestantia Health, working with Western New South Wales to deliver the Diabetes Organised Evidence-Based Care Programme. So this is the first of the coaching series. It builds on workshop 1, where we focused on what matters to a range of different stakeholders. So first of all, I'd like to acknowledge the traditional custodians of the land on which we meet and in the many different nations across the regions. We pay our respects to the elders past, present and emerging as the holders of the memories, traditions, culture and spiritual well-being of First Nations people. We recognise their continuing connection to land, water, culture and community. We acknowledge any sorry business that may be affecting the communities as a whole, and in the spirit of reconciliation, partnership and mutual respect, we'll continue to work together with Aboriginal and Torres Strait Islander peoples to shape a better health system that responds to their needs and the aspirations of the community. So welcome everyone. Therese, do you mind just giving me a head count in terms of who's online? And unmute Therese, $20.
Oh, I think I'm up to 100 now, Ange.
Yeah.
2, 3, 4, 5. We have 6 participants online.
Excellent. Well,
one room has the 2 ladies in it.
Right.
Heather and Helen.
Fabulous. Rightio. So welcome back. So we started off with the workshop on the 8th of February. So what matters in diabetes care? Can I just clarify, was everyone in attendance at the online workshop? Can everyone do a thumbs up, hands up, some acknowledgement? Yep. Right. Radio. So we build on that. We'll just do a quick reflection on that before we move into the coaching activity. But here we are, coaching round 1. And this is where you consider putting into action some of your learnings and about identifying a problem that you'll want to work on, because we're here to support you through that quality improvement approach. So we'll very quickly follow this up with another coaching session. So, and then we move to workshop 2, followed by 2 further coaching sessions. Workshop 3, 2 more coaching sessions. So we recognise that every practice is different. So, and therefore you'll have different contexts, different operating environment, different challenges, different patient cohorts, different priorities. And that's what the purpose of this session is, to actually explore that operating environment to help you define a problem statement. So what we want to do in this session is, by the end, is we want you to have the confidence to be able to explain the coaching approach that we've adopted. You'll have the opportunity to apply it in this session. We want to capture those peer learnings very quickly from workshop 1 in terms of what matters. We want you to be able to speak with confidence about your challenges that you've faced when you're looking to provide optimal care for people living with diabetes. We want you to be able to explain the context and key factors that either enable or create barriers to optimal care. And then we're going to consider how you define a clear problem statement. So the clear problem statement is step 1 within Model for Improvement, because until we define that clear problem statement, we don't actually know what we're working on. So, and then we'll consider next steps. So this is what we're going to do. So the green flags there highlight the fact that there are a number of worksheets that Therese will drop in the chat box that are available to you. The first of which is that knowledge capture sheet. So we supplied that in workshop 1, and we'll supply it in each of our coaching sessions. So this works on that construct of the what, the so what, now what, So if you want to capture any learnings, that's the what. Any key points, that's the what. So what is your reflections in terms of what it means to you, to your patients, to your practice, and your team and other key stakeholders if you want to extend the team. And then the now what is what actions will you take forward. The analyse the context worksheet is available to you. We'll be doing some of that in this coaching session. So we'll apply that coaching action learning approach. And again, there's a worksheet available to you there if you want to do further analysis outside of the coaching session. And then there's also a worksheet available for you in terms of defining your problem statement. So that robust evidence-informed problem statement. So if that's what we're looking to do, has anyone got any questions before we move on and do a little reflection? I take silence as permission to move on. My apologies, you'll see my head turning. I'm working off two screens side by side, so my apologies. I just sometimes need to look to the left. So, radio then Paresh, reflections. Quick recap of workshop 1 and then reflections from everyone in terms of what the what so what now what was on that session.
Great, thanks, Ange. Hi, everyone. I'm Paresh. I'm a GP based in Canberra. Great to join you this evening. One of the things I love about this webinar is I learn as much as, despite being a facilitator, I learn as much as you do. And we're doing a fair bit of work on diabetes in our practice at the moment. So I'm really looking forward to learning together. When I think about the last webinar, one of the things I think we did in the last webinar was very much sort of think about what matters, and we looked at what matters to people from different lenses. So we kind of started off, I think, thinking about what matters to patients, families, carers, and looked at it from that lens. We then looked at it from the lens of the practice team and what matters to you and the team members in the practice. We also looked at it from the lens of the practice itself, as an organization, as a business, and what matters to the practice. And finally, we thought about who else is involved in the care team when looking after people living with diabetes, and what is it that matters to them. So we kind of did this sort of 360 approach, I think, looking at what matters. And the common themes that came up, from my recollection of what matters from a patient's, family's, carer's perspective, I think very much there's this kind of idea of it's about all of me, not just my diabetes. So, holistic care. There's certainly elements in there about preventability, whether it's prevention of maybe even diabetes itself, but if they've got diabetes, trying to push it into remission. But if that can't be done, prevention of complications. So there's a theme around prevention at various different levels, depending on one's journey in their diabetes. There were themes around accessibility, and accessibility, I think, was around two things. One was affordability and equity. And so people being able to afford care and get access to care irrespective of, social determinants. But the second thing about accessibility was just access to services, whether it was primary care services or whether it's GPs, allied health, or whether it's more specialist services and the endocrinologist. So just that access to care. And then I think the final thing that really came up for people living with diabetes was the whole relational aspect of care. So actually being able to connect with someone who's looking after them, having a lot of trust and confidence in that relationship. was something I think that stood out as well. And then if we move on to looking at it from the perspective of team members and what sort of mattered to you and team members, um, again, there were some common themes. One of the themes was having time to deliver the care and the service and not sort of feeling rushed with it the whole time. And so being able to deliver that service was a big part of it. Being supported in delivering that service, having the right equipment, the right technology, the right data, the right information at the time it's needed when the patient's in front of you was, again, something that was important and mattered. Of course, doing a good job, both in terms of experience and the care provided to the patient, but also in terms of those longer term outcomes, mattered. So, good processes, good experience, good outcomes, all really mattered. And then I think there was a sense of that coordination part mattered. So knowing who to refer to people, where to refer, when to refer, how to refer, all that around referral pathways were things that were important. And then if we look at the practice, as an organization, as a business, what mattered there? Again, there was lots of similar themes. Having and being able to provide access to services for patients mattered. Having the workforce to be able to support patients and providing that care mattered. But not unsurprisingly, from a business perspective, the other things that mattered was the need for adequate resourcing, whether that adequate resourcing was around actual monetary, so funding, and reasonable funding to support the care of the patient, or whether the resourcing was around workforce, or whether it was around the infrastructure, so the systems, the technology, the IT, the data, to be able to deliver the care effectively. And then the final piece, I think, was really looking at who else in the system is involved in the care team and what might matter to them. So certainly LHDs came up in that, and the importance of preventable hospital admissions and presentations mattered. From their perspective, from a specialist perspective, having good access to primary care mattered, because good access to primary care meant that those specialists had reduced pressure on their services and were really only seeing the things that they needed to be seeing. That whole care across that pathway leading to a greater level of efficiency mattered for the whole system as well. So, cost effectiveness of care. And then finally, I think one of the other things that came up around other stakeholders was good care around the transitions of care. So when people move from one care setting to another, whether it's from hospital back into the community and discharge, or whether it's between care teams, the adolescent diabetic transitioning into an adult service, or somebody being discharged out of a specialist service back to GP care, all those transitions, it was they particularly mattered around making sure that there were smooth transitions. So interestingly, when you look at it from all the different perspectives, there's some common elements that cut across everyone's perspective. And then depending on where you sit in the system, in terms of diabetes care, there were some things that were more important and more specific based on where you sat. I might stop there, Ange.
So Paresh has given us a comprehensive run through in terms of what the key takeaways were from workshop 1. Have you got any reflections, any observations, anything you would want to add or or adapt in relation to what Paresh has said. So feel free to take yourselves off mute and join in the conversation. Any of your key learnings or takeaways from the last session?
Hi, it's Rebecca. I'm a registered nurse working with integrated care in the community with Plan Care for Better Health. And one of the things I find working with the LHD and not being part of a specialist diabetes service is sometimes I'm working very much in the dark with patients. And I think that connection to primary practice is really important because often patients will come to me and I ask them all sorts of questions around diabetes management, but I'm not sure what's actually going on for them, especially when they don't understand it well. I don't have access to their blood results, their HbA1c and so on. So I'm writing letters back to the GP to say, please review the diabetes cycle of care, which has probably been done. But I think I need to think about how I can improve that better so that I'm working better with the practice nurses and the GPs, if that makes sense.
Fresh comments, observations? Rebecca's clearly defined a problem.
Yeah. I can relate to what you're saying, Rebecca. We have a nurse practitioner, diabetes educator that's just started at the practice, and she came from an LHD, so she's working in an LHD, and so what you're saying can totally relate to, because that's been some of the commentary from her as well. And I think what you're really speaking to is that problem around integration, isn't it? Is sort of shared data and having that information shared across the system,
Yeah.
because
It's around integration, but also consistency, so that we're giving people consistent messages, not overwhelming them with too much information, not damaging their trust in the system and in the people that are looking after them. And it'd be great if there was like a diabetes diary that they could take between services, I guess a bit like a blue book when a baby's born or something like that. I'm not sure.
hold
Yeah.
on to that thought, because in this kind of quality improvement journey, I guess what we really focusing in on today is, from each of our perspectives, what are the problems, like what's a pain point, what's a problem we want to be looking at and exploring and solving. We then want to do a diagnostics on that problem before we go in with solutions. But that idea of a person or patient held record, which moves around with them around diabetes, could be something. But there could be some other solution there as well. So let's, when you think of an idea or a potential solution, hold on to it, and we'll come back and visit it after we've been through a bit of a diagnostics process around why that problem exists in the first place.
Yeah, thanks.
Anyone else got any comments, observations, reflections on what matters and who it matters to? And just to let you know, I'm capturing it on the whiteboard as well. So.
I have a comment. I raised it last time as a allied health dietitian, and I think this goes across dietetics in general, that dietitians are viewed as people who like to take away food and restrict food for people, which is not actually what we do at all, really, but that consequently has a very low engagement, particularly in something like diabetes, which is obviously a very food-related condition. And consequently, people really don't feel like they want to come and see a dietitian because we're going to tell them potentially that they shouldn't eat certain foods. And that's not necessarily going to be the case. We might educate them that they could change the types of foods they eat. But I guess I get this a lot, that people don't want to see a dietitian, but they might see a nutritionist. When in fact they're one and the same. I mean, I'm a nutritionist first and a dietitian second. So that's a real pain point for me, because I'm trying to encourage people that I'm not going to take food away from them or put them on restrictive diets or that sort of thing. So I think it limits people's opportunity to get help from people that could really help them.
Thanks. And now, is it Helen or Heather? Helen.
I'm Helen.
All right, great. Thank you. Thanks, Helen. Let's hang on to that. And again, we've been invited to do a talk on Sunday to a sort of multicultural association. And so we're going to so I'm going to go with our nurse practitioner, diabetes educator, and exercise physiologist. We're today just talking about it, and the audience will mostly be Asian and South Asian, in particular, where food's a big part of it. And we were kind of just having exactly that conversation, like, I don't think they'll want to be hearing us saying you can't eat this and you can't eat that. It's about how can you live with diabetes and manage with your joy of food, and trying to sort of reconcile the two. So I again empathize with the challenge. It's kind of quite raw for us at the moment, preparing this presentation for Sunday. Anyone else?
Feel free to add any additional reflections, light bulb moments in the chat as we move through. So Paresh, how do we do what we do? And what can people expect from us?
Yeah. Thanks, Ange. So I guess, in terms of this program, there's the workshops, and we've got a few workshops, and Ange showed the slide earlier around how the program's constructed, and then we've got the coaching sessions in between. And so today's a coaching session, and for me, as a clinician, the coaching sessions are a bit like what we do with patients as well. It's so in terms of your problem around not having access to information, Rebecca, when you're seeing patients, and Helen, yours around perception of people around what dietitians may say or do. Our role in these coaching sessions is not to provide the answers, because we don't necessarily know the answers, but even if we did, it's about exploring what those problems, exploring what the potential reasons might be for those problems. So just as we do with patients, take a bit of a coaching approach in terms of their clinical care. In this program, we're taking very much a coaching approach in looking at these problems and how we might address them. And the coaching structure we adopt is called the growth model. So it's on the right-hand side of this slide. So the G for growth is very much around goals, and not only your goals for the duration of the program, what you'd like to achieve by the end of the program, but your goals for this webinar. So in this coaching session and the next coaching session, and so we'll kind of come back to that in a moment. But and Ange alluded to this earlier. We all work in different practices. There's a reality out there, isn't there, for us? Like, if everything was hunky-dory, like everything lined up, we had infinite resources, we had total interoperability in our tech solutions, our tech worked 100% of the time, every time, our patients turned up to every appointment on time, And when for every pathology referral, specialist referral, things will be wonderful, but that's not the reality. The reality is we live in this messy world. The tech doesn't always work. The tech certainly doesn't connect across. We have workforce issues. So, I saw a message just flick up around needing a diabetes educator in the was it the LH in rural hospitals from Jennifer. So, we have workforce issues, we have the tech issues, we have the funding issues. The funding doesn't really kind of flow. And then we have, the variability in patients, the variability in access. So our reality is living and trying to improve the care of people with diabetes in a bit of a messy world. And the mess in your world, in your practice or your LHD or wherever you work will be different to the mess in my world, but we all live in a messy world. So it's really thinking about how do we achieve the goal we want to achieve in the mess of reality. And so the idea of the exploratory conversation is to try and generate options of things we could do. Those options could be about narrowing the scope of the problem. It could be when we're sure about the problem, we understand the problem, what options do we have around trying to improve it? Is it a patient health record? Is that one option? Is it something else? And then the way forward, how will we take that forward? And when we think about the way forward, we're thinking two things really. We're thinking tactical. So what are the tactical things we can do? But more importantly, how can we make it sustainable? So how can we hardwire and embed it into usual care? So in a year's time, 2 years' time, 3 years' time, we're not back around the same table having the same conversation. And I'm sure many of you have probably been there in the past having similar conversations. So that's kind of the approach we're taking. And so that's a great segue into saying, in the rest of the time we have, which is about an hour, what would you like to achieve? What would, by the end of the session, what would you like to address? What would your goal be for this session? Anyone want to share?
Sorry, I'm sitting in a park in 39-degree heat and I'm trying to get my phone to work. I think I'm in general practice and I'm in Cowra. So I only sort of know what I've sort of worked out myself. When you're trying, I find it really hard. You've got family, work, elderly parents, lots of other things where we don't have time to reinvent the wheel. To have some sort of support, we've had a few meetings, a couple of talks and stuff recently with the PHN. And there's all these things that they can offer us, and they're going to continue coming to the practice and having meetings, which is awesome. It's all these things that half the stuff they talked about, I didn't even know was available or existed. They go, oh, you do know about this? No, because I've never been told. And when you don't know things are out there, it gets really hard and quite isolating. I'm the only educator here. So having some sort of some sort of online system somewhere where we've got all of these things. This is, where you go to, trying to get reps, they disappear in the black hole if they go over the Blue Mountains. I've got a couple of reps who are really, really awesome and, have good contact with me. Others you try and contact. So in a small service, they're not that interested because they're not going to make much money out of you. So then you don't get extra info on technology and stuff. Trying to work with base hospitals, sometimes management aren't that keen because you're a GP pleb. I find all that quite, we all should be working together. We're seeing the same people. We're trying to do the same job to look after people for healthcare. So some sort of place where, whether you're hospital or GP land or allied health or something, you know who to go to contact for things or find out about resources, technology, all that sort of stuff. That's my big thing, because you're trying to do all your clinical and get all your paperwork and stuff, your clinical hours. You don't have time to be, you know, doing 7 hours a day trying to find stuff on the internet. So it needs to be some combined area where we can all work together and get this stuff going, I reckon.
Yeah, great. Thanks, Jennifer. So the problem I'm hearing from you is there's assets and resources out there. We just don't know where they are, how to access them, and whether, you know, they meet our needs or not. And sometimes the resources or assets that might be out there may have a reluctance to come to us, especially if they're commercially driven because of smaller markets, etc. Have I paraphrased that correctly, Jennifer?
Yeah, some of that's quite correct. It's I think also the fact, sorry, like GP land, diabetes education's quite, it's not really terribly viable. Like the EPC system is like so outdated for someone with a chronic condition like diabetes. They've often got thyroid, they might have celiac, they've got depression, all these other things, and you get 5 visits a year. So if they're using those 5 for podiatry, they've got nothing less for diabetes. Half the time they're on pensions, or they've got kids with special needs they can't afford. So I think that equity in general practice is just not there. Like some sort of, we need to make it more viable to have diabetes educators in general practice. And also hospitals, like at the moment I'm trying to get a casual position 1 day a week at our hospital to do diabetes education, staff education, and start a clinic, because it's unreal that we don't have. I have people approaching me asking me for help, and I'm employed by one practice, but I still get people from the other practice sort of asking me for help, because the base hospitals are absolutely flogged. They've got so much, so many people to see working in the hospital doing clinics, and there's not very many of them. So I think all of that needs to be re-looked at.
Yeah, that's great. Thanks, Jennifer. So I think in terms of that problem you identified, that you've started to do a bit of a diagnostics on the reason for that problem. You know, capacity is an issue, funding is an issue, the way the system works, at least as far as MBS goes, means people have to prioritize between the different allied health services. So I was going to ask Helen, maybe we'll wait for when she comes back. So, you know, Helen's comment there around people's perception of dietitians, and so I was going to ask Helen the question around, if that perception wasn't there and people were willing to come, would we be experiencing? I was just going to ask Helen, the comment you made about people's perception of dietitians. I was just going to ask, if that wasn't there and you had people wanting to come to see you, do you think what Jennifer's identified around limited ability to use Medicare rebates and things would be a barrier for you as well?
Yeah, there we go. Yeah, look, I think a lot of people do tend to use up their EPCs on podiatry, because they can just sit back and have their, like, it's much easier to go and see a podiatrist and have something done for you, rather than have to sit and do the hard work to see a dietitian and talk about food and diet. And I think the perception there again is just, you know, they're going to change stuff, and that's really, really hard. It's harder work to make dietary adjustments. So the 5 EPCs is really minimal. And I think the other thing that people often don't understand, and I'm at pains to explain, because I actually specialize in eating disorders, so I've got a lot of people on eating disorder plans, and they often say, look, it's just so expensive to come. But, you know, trying to explain that safety net that often comes in after a certain amount of time. And so pensioners would be on the lower safety net, and that comes in at about $600 out of pocket. And then for other people, it's about $2,500. So, I mean, they're things that you can explain to people to help them with costs. So I can sort of hear in a way that the cost of care is high, but the government does catch you at some point as well.
Sorry, I had myself on mic. Yeah, totally. So, you know, again, we're kind of jumping ahead for future coaching sessions around potential solutions and maybe educating people around safety nets and things. So again, let's hold on to that a bit, like the patient health record, to come back to when we've been through a sort of systematic diagnostics process. But great. Ange?
Yay! So reflections on what we've talked about. We're actually jumped straight into the agenda, Paresh, haven't we? So in terms of the goals for this session, our goal was to take you through a process of identifying what your problems were and analysing those problems. And we've launched straight in there, so that was good, and to understand the context. So so yeah, we're done, Paresh, are we? Sorry.
Not quite.
So we've got lots of problems there. So from the top, we've got that problem of integration. So in terms of access to data, consistency across services, that's where the patient health record came in. We've got that lack of resources. So diabetes educators, that it was mentioned in the hospital in the LHD setting, but I think it extends beyond that. So then we've got a lack of understanding or lack of a system that helps us understand what's available to us in our communities, our diabetic patients, who they are, where they are, what they provide, how we can access them, and so forth. So that's a problem. We've got a problem of perception in terms of the role of the allied health, and that was specific to dietetics. And similarly, that came up in a group coaching session I did at lunchtime. And then also we've got this problem in terms of EPC being out of date, potentially creating barriers to access to services, when actually the purpose of EPC, the initial intent was to look at that holistic care. But the problem is the limitations on that. And then obviously there was that conversation had about people not understanding the MBS safety net. Anything else, Therese? Therese got a hand up.
This is the multi-million-dollar question. Is there any pressure? You may know a bit of more insight. I'm not sure. Is there any chance with the changes that are coming for EPCs to be extended with the removal of the 723, the potential upcoming of the removal of the 723? How does the EPC side of things work? Have you had any inside privy information that you are happy to share? If not, that's fine.
Yeah, I'm not sure I've got any information to share, to be honest, because I don't think anyone's really worked it out in terms of the department. So I think what Therese is implying is, so we know that the government's thinking about changing the 721, 723 approach. So at the moment, we've got team co-arrangements and there's all this paper flow around things going off to allied health and being part of the care team. And we also know at the moment that follow-ups on care plans and team co-arrangements aren't very, very good. So there's certainly plans going forwards and the current thinking, although this is not totally confirmed, is that probably from November this year, GPMPs and TCAs will only be rebatable when a patient's registered under My Medicare with a practice. So only that practice will be able to do the care planning. And then the second element that's being thought about is pulling the GPMP and team care arrangement together into the one, so you don't have to do two separate things. And that, if you've done a care plan, that just entitles you to the allied health item numbers and rebates. And then probably a redistribution of the total pot of money. So it's doing the care planning at the beginning doesn't get as much, and the follow-ups get more. So still keeping the pot of money used for EPC the same, but incentivizing follow-ups by increasing the value of rebates for follow-ups and reducing the value for the initial GPMP TCA as it currently is. So I think that's what Therese is alluding to. Whether that changes the number of EPCs people are entitled to, we don't know at the moment. Not much has been said about that. In parallel to all of this, the Strengthening Medicare Task Force strands of work are also looking at multidisciplinary teams as being a big part of modernizing primary care going forwards. What form and shape and how that happens is still not clear. There's a parallel piece of work happening, and they've just completed the first phase of it, which is a review of the scope of work for different team members in primary healthcare. So trying to understand what is the scope of practice for a dietitian, what is the scope of practice for a diabetes educator, a physio, a GP, a practice nurse. Where's the top of scope of practice for them? What are the enablers and barriers there? And certainly there's some regulatory barriers and professional barriers there. So that first phase of that reviews happen, which is really exploring what the problems are and what the barriers are. The second phase has started, and I think there's 4 phases altogether, which will finish in about a year's time. So I think it's fair enough to say there's change coming. What that change looks like, we don't know at the moment. A bit like what I've been saying to you around, patient health record is a potentially good idea, but let's hang on to it until we've done the diagnostics. Patient education around the role of a dietitian, potentially a good idea, but let's park it until we've been through diagnostics. In a similar way, government is doing exactly the same thing, Therese. So what they're saying is, let's get the information, let's gather the data, let's do some diagnostics on where the problems are, and then we'll come up with the solutions. And that may or may not involve change in the number of allied health item numbers. But I think what we can be sure about is there will be change.
Yeah.
Does that help?
Thanks, Presh. Sorry to throw you in there.
No, all good.
It was sort of starting like just with
Yeah.
Jen's chat as well, and it was sort of going that way. I thought that might just be be a bit of incentivizing to how the mapping might start to happen.
Yeah, no, all good.
Thank you.
As part of our program, I think one of the added benefits of the program is the fact that we've got a methodology that we use that can be applied in any scenario and any setting to help you first of all explore and then manage the change you want to see in your practices. So the only constant is change. We need to be agile and adaptive to be able to respond to that change. So one of the added values is that the methodology we have for quality improvement can be applied across all change activity and practice transformations. So where are we up to? Now we were going to put up this slide. Pressure, we're going to do a fishbowl exercise.
Well, I'm just going to say we've heard some voices, but there's some other voices we haven't heard, and that's fine if you sitting there listening, absorbing, absolutely fine. But we also want to just make sure if you want to say something, you got the opportunity to say something.
I've captured 1, 2, 5. Feedback from 5 people. Sorry, I can't see the numbers on the screen. Yeah.
So Heather, Natalie, Neil, Nicola, Susie. I think we haven't heard from you, and that's fine if you don't want to say anything and you just actively listening. But if you wanted to, please feel free to jump in now. Yeah.
Have we heard anything from Neil as well?
No, you haven't heard anything from me. My background is in general practice in Narromine, and it's just interesting to hear from the people in the allied health sector. And I mean, in preparing for this, unfortunately, in our practice, we have visiting allied health professionals and highly skilled practice nurses. So I sense that some of those allied health professionals we've heard from sort of feel a bit as though they're operating in isolation, and I really feel for them, and I think it's just so beneficial for us as clinicians to be working, or for one to be working in the same building, and to sort of be able to have corridor chats and corridor education on a fairly frequent basis, and it sort of enriches our professional lives, enriches the lives of our patients. So I think my goal is to sort of just improve on what we're trying to achieve in our little neck of the woods. So yeah, I'm interested to hear what's going on, and happy to listen, but also happy to share the benefits that we're enjoying with having PHN funded services coming into our practice, and also employing our own nurses. It's a wonderful way to work, and yeah, can't speak too highly of it.
So thanks, Neil. So that makes it very clear that your context, your operating environment is very distinct and different from some other practices. So, and with that added support, this is my reflection and rewording of what you said, with that added support. So for examples, and I didn't capture names, apologies. So knowing what's out there, it sounds to me what's out there has the potential to come into your practice. So that extended care team is coming into the practice on that co-terminus, co-location basis. And from that, you're able to build that more of a team-based care approach. Is that a fair reflection?
Exactly right. And we've been doing it for a little while now, and thankfully, some of the issues around cost of services are not experienced by our patients, and I think we've been able to enhance our care of patients' diabetes by talking about the benefits of seeing a dietitian, talking about, for instance, talking about how they're not going to tell you what you can't eat. So really, and I can think of a few patients where I've spent a number of consults over several years, sort of encouraging them to see a dietitian, and then when they do get to see them, they're very grateful for what they've been able to do for them, and as a consequence have improvements in their care.
So Neil, I get the impression you're living in utopia.
Well, it's real. I think it helps all of us to,
Yeah.
you know, we're certainly not perfect, and we're learning and improving all the time. We want to improve, but you know, I just feel for those allied health people who seem to be, you know, it must be a real struggle for them, you know, to up against, you know, some of the barriers they've described.
So recognising that your operating environment, your practice, your infrastructure, the support you've got and access to them is distinct and different from others. Have you got any problems? Have you still got remaining problems?
Certainly, yes. Yes, we're not perfect. We've got, well, one of the barriers, one of the challenges that I've found with some of my patients relate to overcoming not only issues of health literacy, but literacy in general, and just understanding how they might be barriers to people seeking care in the first place, and then understanding their care and trying to work around that, you know. So, and that's one problem, you know.
Any other problems?
Do you want me to go with more, or?
Yeah, you go.
We have issues around, obviously, the compliance, patient attendance, and some of these issues that have been raised. I asked some of our practice team to sort of think about what they're encountering too. So what I'm putting forward are some of the issues that are coming forward from our practice nurses. Helping, you know, encouraging people to change their behaviours, their eating behaviours, obviously. And there's, you know, really there's not enough of our GP services to be able to deliver to all of the people we'd like to all of the time. But I guess one of the things we found really helpful, you know, the access to specialist care is we've had a working relationship with an endocrinologist who's very flexible in providing telehealth to our patients. So that's really enhanced our service delivery dramatically over the last couple of years. So, so that's we've overcome the lack of face-to-face services. Not overcome, but we're certainly addressing the issues around accessing specialist endocrinology services. And we've got one of our receptionists sort of takes responsibility for liaising with the endocrinologist's reception staff, and we've got I think we're streamlining that process of getting appointments with the endocrinologist. So that's not really a problem. That's overcoming a problem, I guess, you know.
Yeah, no, it's good. It's good to know how other people are fixing problems in the system. So that's good. Now, Suzanne, was it Suzanne? I brought Neil in to give you a bit of breathing space. So would you like to share?
Ange, can I just ask one quick question of Neil? Sorry, Suzanne. Neil, do you guys use Inca?
I beg your pardon?
Do you use the platform Inca?
I don't know. Oh, Inca. No. I couldn't be certain. No, I don't think we do. We don't.
No, that's okay. It was just something. It's a shared platform. So I was just wondering if that was something you use with your specialists and your allied health service, but that's okay.
Good.
Thank you.
Sorry, correct me if I'm wrong. It was Suzanne, was it? Rush?
I just had a point. This is Heather. I'm a GP in Dubbo. It's probably already been covered by people, but one of the main barriers that I find in helping people with diabetes is
patients struggling to engage with their diagnosis and the fact that they actually need treatment and that they actually need management. Quite often they feel quite well, and the thought of high HbA1cs causing retinal problems or renal problems in 10 years' time doesn't feel very pressing to them. So so one of the barriers that I find, once people do develop problems, they become typically more motivated, but obviously we would like to prevent problems. So that was just one comment.
Thank you for that. Rash, over to you. I'm frantically capturing stuff. So.
Great, thanks. So, look, I'm going to be a bit adaptive to Therese again, and don't worry, I'm not going to ask you to put us into breakout rooms because we're a relatively small group. I think the richness of some of the things people have raised is absolutely fantastic. So what we did, so we did a similar webinar earlier today, and what we did in that webinar was we invited one of you to come forward as a volunteer, and we had a bit of a coaching conversation. But I'm going to be a bit adaptive because many of you have come up with, various areas and problems. If you're all happy with the suggestion that we continue as we are, as a little bit of a group coaching and sort of having a group coaching conversation, what I'd suggest is we just continue as we are, but I'll perhaps be a little bit more questioning around it to just explore things a bit more. Would that be okay? Ange, you happy with that plan?
Absolutely.
So, there's a few things we've heard around this. Just thinking about Heather, going to start because primacy and recency. So the bits in the middle will slowly come back to me, but you were the last person to go, so that's a bit that's retained here at the moment. That issue around patients and their willingness to engage, can we explore that a bit more? And whilst you raised it, you're not the only one who has to respond to the question. Other people, please feel free to jump in as well. What do you think's behind that? So let's just explore that a bit more. Is it all patients, or is it certain groups of patients? What data do we have that kind of tells us how much of a problem this is, and with whom is it a problem? Have we got any data around that? Do you have a sense of if we were to sort of focus in, how could we identify that population?
That is a good point. I probably made that observation based on vibe and feeling rather than data. So pulling some data would be quite interesting. I can imagine that running a PenCat search with something like patients with diabetes with HbA1c over a certain level and complications, maybe searching for a search parameter like retinopathy or whatever search parameter would be a starting point. Probably I'm more reflecting on my conversations that seem to happen on repeat in consults, which tend to revolve around, how are we going with your exercise levels and how are we going with, what you're eating? Or people will come in and say, oh, I know my HbA1c is going to be bad this time. It's like, why? I know because I've just been eating crap. Okay. And then they say, I know what I have to do. I know what I have to do. No one's going to tell me what to do. I just have to do it. You know, there's this constant repeat, but I'm then reflecting that we've had the same conversation for about 2 years.
Yeah.
And then one can offer, you know, well, would you like to check in with, you know,
The dietitian.
a dietitian? Or,
We work together, so we own the practice together. So
yeah,
it's.
but then people's response is usually a bit of a pushback. You know, no, I know what I have to do, or I've seen someone last time and it didn't help. So I suppose I'm just reflecting, but I suppose what would a way be to collect that data? Maybe it would be to look at referrals issued versus the uptake of referrals.
Mhm.
You know, if we've actually suggested a patient sees a specialist or an allied health provider, we could look at, yeah, what's the actual uptake? Limitations to that would be that we sometimes don't get correspondence back when we should from the provider. So we may not be able to know that they've seen a provider unless we ask them.
But you could just search on Coda, couldn't you, to see whether they've used the EPC?
Mm-hmm.
You can usually see that the token's taken.
Yeah, so you might be able to, if you go hunting, know that they've seen someone, because, you know, if you go onto My Medicare or something, you can see that, sorry, not My Medicare, My Health Record, you can often see their sort of billing history. So you can see that they've seen someone and had a certain billing code, but you don't necessarily know what's been said. I'm just going to, a little tangent, but sort of deliberate in that when I say data, naturally people assume numbers, and I'm a numbers nerd, so I do like that. But I actually think the soft data, so the qualitative stuff, is just as important, and that's data as well. So I deliberately asked the question in the way I did, partly to pull that out, because I think when we think about doing quality improvement, particularly these sorts of slightly more challenging problems that we want to solve, having a combination of that mixed qualitative data, like what are people feeling? Are other GPs in your practice noticing similar things? Are there any common patterns around the patients that seem not to engage, that we're noticing? So that sort of qualitative data, qualitative information is just as important as the numbers, and it's a story we get from sort of looking at both. So we want to be sort of weaving in and out around both of them. But you know, I think qualitative data is pretty important as well. So so just pushing that a little bit further. Do we do you know? I'm just sort of reflecting on my practice. And there's some patients that are really good, like they'll just come, you know, and they turn up, and in fact they're the ones, you know, sending me an email to say, you know, my recall was this week and I haven't had my pathology yet form, and so you got at one end those sorts of patients, and I am in Canberra, and you know it is a public service town, so so we have got some patients like that. But then we've got patients who you can call 2-3 times, can't get through. They won't return the phone calls. You can send them a letter, don't respond to that invitation as well. Is there a way you can think about identifying those patients, like who is where in that cohort? Does anyone use any tools around that? I don't know whether whether Rebecca or Helen, you may have come across any tools like there's some tools out there like
There
patient
is a
activity.
tool that the LHD uses. It's in the patient flow portal called the CCOPS. We weren't using it for a while, but we've only just started using it again because it identifies various psychosocial factors, including health literacy, alcohol and other drug use, cognitive impairment. And just in my experience of, and I'm sure everyone has as well, the more factors you add to somebody's history, the less likely they are to manage well or to be motivated to manage well. It's not that they're not motivated, but they struggle to manage their diabetes well. So alcohol and other drugs, cognitive impairment, and really poor health literacy, mental health issues are problems. And I've noticed there's a very small group of people, it's not everybody, but there's a small group of people that really need ongoing case management, not just care coordination, but somebody that can actually guide them and help them to remember appointments and ring them up and say, look, you're due for this, and even pick them up and take them to appointments. They're very small, a very small group, but I don't think we're doing that very well anywhere, and even in our bigger regional areas. That's just my observation.
Yeah. And the reason I asked the question, and thanks, Rebecca, for sharing that. The reason I asked the question is, when we thinking about doing quality improvement and stuff, we tend to use a bit of a one size fits all approach. So we say, here's our people with diabetes, and we want them to have this cycle of care stuff, and we're going to put a recall or reminder in, and we're going to send out a letter, and we're going to do a message, and they're going to come and see a nurse, and then we're going to offer them an appointment to see a dietitian or a diabetes educator. We tend to do a one size fits all approach. And one of the things I think that's really interesting is this whole kind of concept of consumer enablement. So some people have a certain level of literacy, confidence and skills to then act on that literacy compared to other people. And Ange and I have done a fair bit of work on something called the patient activation measure, which kind of measures the knowledge, confidence, and skills a patient has around their own ability to look after their own health. And one of the things that kind of came out of that is somebody who's perhaps got a lower level of patient activation compared to somebody who's got a high level of patient activation, we might actually do things differently for them, right? So someone who's got a high level of patient activation, like the public servants who come to see me in the practice, who are constantly sort of emailing me, asking me for that pathology referral because I haven't quite done it yet. For them, it's sometimes about having a plan and a safety net. So if they don't email me, we pick it up. But for some of the other ones, at the lower scale of patient activation, we want a bit more of a proactive approach. Like we want to be hand-holding them a lot more. And so my question to you, Heather, around, do you have a sense of or do you have any data around how you might identify those people? I guess that's what was going through my head is, is there a measure we could use to try and identify one group with another compared to another group, and then can we tailor our approach based on their level of health literacy, confidence, and skills? Do we actually measure their health literacy rather than a finger in the air judgmental approach to say, oh, that person's got low health literacy and that one's got a high health literacy? Like, is there a way we can measure that? And so what I've done is in the chat put a couple of links in. the first link is to the Agency for Clinical Innovation produce a consumer enablement guide. And in order to produce that consumer information guide, one of the things they did was looked at all the different tools that are out there to measure consumer enablement and did a bit of an appraisal. So the second link is about those tools. So I thought that might be useful. Again, not to use now, on the parking lot when we're thinking about things we can do in the future, improvements we can make, maybe something to consider. Rebecca, coming to the data issue you talked about, like not knowing when you see patients where they are, who they've seen, what information you've got. What do you think is what are the reasons contributing to that? Why does that problem occur? How often does it occur? Like, in the last week, if you saw 100 patients, would it have been a problem for one of them, 10 of them, 50 of them? How much, what's the scale of the problem?
I work with a cohort of patients that's sort of near the tip of the triangle in terms of complexity. So the majority of them have difficulties following medical recommendations. They're the patients that often are stigmatised, labelled as frequent flyers in the hospital system, and there's chronic disease, but often comorbid, as I say, cognitive impairment, very poor health literacy, people that have left school early in high school or earlier, alcohol and other drugs, childhood sexual assault and other traumas, so quite complex. And I think within that group, there's a lot of factors that contribute to difficulties navigating the health system. Yeah. And then we've got elderly people as well in a world now that's becoming much more technological, where they're sort of being left by the wayside. And some are brilliant. They'd run rings around me in terms of technology, but some are really, really struggling with it and can't use their mobile phones very well, and so on. And then the more rural you go, look out around areas like up in Condo and then out to Lightning Ridge and Nyngan, we assume that everybody's got access to smartphones and laptops, but that's not actually the case either. So often what we're expecting people to do isn't well aligned to what they actually can do and the resources that they have. And I think it's all too hard. It's very frustrating. It's frustrating for me sometimes trying to help them, let alone how frustrating it must be for them trying to work it all out.
Yeah, no, it's fascinating, isn't it? We often, I think, are a barometer around the frustrations our patients feel with it, because we often feel the same frustrations. Okay, so you identified a few things. So you identified patient complexity as a contributor to it, which is one factor. You've identified technology, and I think what you identified is two parts of technology. One is actually, just as you have health literacy, you also have digital literacy. And so I think what we're identifying is maybe there's a cohort of people with low levels of digital literacy as being one issue. I think there's a second issue there. Actually, I think you've identified three issues with respect to technology. I think there's a second issue around actual access to technology. So just as we've got access to specialists or GPs or allied health, we've also got a barrier around, I think, access to technology, particularly in lower socioeconomic status. So affordability of internet or broadband or things, and people often change mobile phones very rapidly, like very quickly, because they go from deal to deal to make it affordable, which means that consistency of engaging with them becomes harder because of that. And then I think you've alluded to earlier, not so much now, a third problem around technology, which is we don't really share it, do we? Like what you have in the LHD is different to what we have in general practice, and it's
even
different.
within the LHD, there's
Yeah.
so many different systems and none of them communicate with each other. So I might have access to one system, but I don't have access to probably 6 others. So it's very clunky, it's not user friendly, and it's certainly not conducive to open communication. And the other factor I'm starting to see more of is homelessness and issues around homelessness. So when people haven't got a stable place to live, that makes managing any of their health problems difficult and accessing services difficult.
Yeah. So that kind of comes back to that patient complexity is another variable in that patient complexity. So just a little sidebar. There is going to be a frequent hospital users program that comes out in August this year as part of strengthening Medicare task force, which is going to look at some of these elements we talked about, and people at a high risk of hospital admission will be enrolled, and practices will be able to take on a level of activity to try and support keeping them out of hospital with an alternative payment model that's not fee for service, to support them. But it won't be every practice, and it won't be every PHN to begin with. It will be I'm not sure how many PHNs, but it will be a relatively small number of PHNs to begin with in August, and then within those PHN areas, it won't be every practice. It'll be a small group of practices, and then with time, it'll kind of expand. But that's coming in August.
Haresh, do we know when they're making the decision on the PHNs? Because there's 9, I believe, that are being selected.
Yeah, I think it's being made at the moment. I'm in Melbourne next Thursday for the final working design group meeting, which is going to be around the evaluation, and we've had 3 other meetings since November, so it's kind of imminent, I think.
Thanks.
Paresh, can I just go back to the conversation we had around health literacy? So I'm mindful of time. So inherent in health literacy is a concept of your condition. So understanding how you manage your condition, but as part of that, there's also the concept of system literacy in terms of understanding the system, the health system, and how you operate as a patient within and across that health system. So I think the system literacy often gets lost because we just sort of put it under the umbrella of health literacy. But I think it resonates with the complexity of patients, I believe Rebecca was talking about, but earlier in terms of when someone mentioned, even as a clinician, you don't understand what services are there, how to access them and so forth. So there's a problem from the patient perspective, but also from the practice perspective as well, from a system literacy point of view. So, yeah.
So we've got about 7 minutes left. So we're going to sort of go into wrap-up mode. But before we go into wrap-up mode, is there anything else anyone wants to say or share, or about the sort of problem that you're looking at or thinking about looking at, and what the reasons might be for it? So what we want to really be doing between, so the whole idea of this program is to think about doing quality improvement with respect to something around diabetes. Yeah. Where we start the journey of quality improvement is understanding the problem that needs solving. We all often want to have world peace, and so we start with a pretty big problem to try and solve. And the whole idea about having this sort of conversation we've been having this evening is to try and unpick the nature of that problem. Because what we want you really to start to think about is, if the problem I'm trying to solve is patients not coming into the clinic and attending their appointments, or patients not coming to see me as a dietitian because they've got misperceptions around the service I might offer, or it's to do with the date, the ability to access the information when they do come and see me. If that's the problem we're facing, we need to really think about framing the problem. To what extent can I solve this problem? Okay, because we're not going to be able to, in the duration of this particular program, get to world peace, right? So we're not going to be able to solve a big problem. So we want to think about narrowing that problem down to something that's very specific and tangible we can do something about. The way we get to that point of narrowing the problem down is a mixture of looking at data, so qualitative data and quantitative data. We want to look at, for whom is this a problem? How often is it a problem? How much of a problem is it? When does it tend to be a problem? So we really want to be thinking about the questions that are on this slide and on the boxes here, to try and sort of frame the problem around something that's manageable. Because we then want to, once we've got to that point with that problem, is be able to then flip it into a goal, right? And that's the goal of the improvement you'll make over the course of this program. We want that goal to be specific. We want it to be measurable. We want it to be achievable and relevant. And it's got to be time bound. It's got to be done in the duration of this program. Which how long's the program, Ange? Remind me.
The program runs through to June. So final coaching session on the 5th of June.
Yeah. So we haven't got that long to solve whatever problem you want to solve. So it's got to be manageable. So between now and the next webinar, what we'd really would like to ask you to do is build on the conversations we've had this evening. Think about your context, where you work, and what's the problem you'd like to solve, and think about what data you have to support this problem, to tell you the story of this problem around those W's. So for whom is it a problem? Why is it a problem? Why does it matter? When is it a problem? And what does the data show? And the data can be qualitative and quantitative. Yeah. So speaking to colleagues, speaking to team members, and getting that narrative of what they think is good data, as well as the numbers in primary sense or PenCat. So we want to put both of that in the melting pot to arrive at a problem statement, to try and work on between now and June. Does that make sense? Has anyone got any questions around that? So I think we've shared this in the chat, haven't we, Therese?
There's a worksheet in the chat, yes.
Yeah. And I have sent all of the other resources out. If someone can't access the chat or can't see any of the other resources, please just email me and I'll get it back to you.
Yeah, and I'll circulate them to everyone tomorrow after the session. So yeah.
Yeah.
So reflections on this session. Any quick reflections on the importance of understanding your context and defining your problem?
So
Any questions?
just responding to the chat around email with resources or forms would be great. So we'll certainly do that. And I guess the problem statement template is the first QI activity template, Jennifer, that we're going to share. So that's kind of the starting point. And as we go in this journey, there will be other QI activity templates to help you. So so you don't have to reinvent the wheel when it comes to how to do the QI. The reinventing the wheel, well, it's not really reinventing the wheel. It's the solutions you implement. It's really looking at, do they work in your context, and then adapting them is where we want to be getting to, and we'll probably get there. Not at the next webinar, but the one after that. It will start the journey. That will be the time when we start thinking about that.
Yeah.
Can I just make a comment? Don't overthink it. Been through this before. Reach out if you're starting to overthink it. Myself or my team will help. So yeah, and nothing's a stupid question.
Yeah.
And we don't all have the same problem, obviously. So yeah, this is based on what we're all interactive, but to help everyone with bringing ideas to the table.
Thanks, Therese. Righto, mindful of time. So as Paresh mentioned, please bring your problem statements to the next coaching session on the 13th or 14th. Therese has kindly sent the invites out there. So if you just want to select which one to join, that would be good. So we'll see you on that one. Coaching pre-work, Paresh talked about. Bring your problem statements. If in the interim, as Therese says, that you need some help, you'd like another conversation with someone, reach out to your practice development officer. They'll be willing to support. And if you're a GP, think about how you can utilise this session to contribute towards your CPD. So you can self-report against the 3 different domains there: education, review and performance measuring outcomes. So yes. So thank you everyone for your participation tonight and joining in. Hope you've got some useful learnings for that. Wishing you well in defining your problem, and then we'll work with you in the next session.
Thank you, everyone.
Thanks, everyone.
Thanks, everyone, for giving up your time.
Good night.
Good night.
Thank you. Bye. Bye.